You're listening to the Future Tech Podcast with Richard Jacobs. Future technologies such as artificial intelligence, stem cells, 3D printing, gene editing, Bitcoin, blockchain, the microbiome, quantum computing, virtual reality, and exploring space are much closer than you might think. In fact, many early versions of these technologies are in play right now, and the companies that are using these technologies are the focus of this podcast. My goal for you, the listener, is to learn from these podcasts. You may very well learn something that may change the course of your life for the better, steer you towards a new career, or give you insight into addressing a thorny medical problem. Remember, this podcast and its content is informational in nature only. No medical, tax, legal, financial, or psychological advice is being given. If you've enjoyed the podcast, please listen, subscribe, like, and tell your friends about it. Thank you. Hello, this is Richard Jacobs with the Future Tech Podcast, and I have John Tucker, DMD, founder of Dental Sleep Medicine Education. Website is Tucker Educational Excellence LLC. And for his bio, I have that he's a graduate of the University of Pittsburgh School of Dental Medicine, and he's completed Boston seminars in implant dentistry, University of Buffalo Aesthetic Dentistry Program, and all levels of the Dawson Center for Advanced Dental Study and the University of Buffalo Patient Mastery Program. And he's a diplomate of the American Board of Dental Sleep Medicine, which I didn't even know there was such a thing. But John, thanks for coming. How you doing?
Rich, thanks for having me. It's great to be with you. I'm doing well, sir. And yourself?
Good. Well, I'm glad to be talking to you. So, what is dental sleep medicine, by the way? Yeah. What is dental sleep medicine?
Well, you know what? It's funny. We're doing this podcast, and this is Sleep Awareness Week. And dental sleep medicine focuses on treating the patients that have obstructive sleep apnea that are intolerant of their CPAP therapy. And CPAP stands for...
I have a friend like that.
You got a friend like that? We all have friends like that. So CPAP is basically a vacuum cleaner in reverse. It blows air down the airway to help pneumatically splint the airway open at night while we sleep.
Okay. Yeah, I've talked to a lot of sleep doctors about apnea, and I've seen CPAPs. It's like a plastic mask that fits over your nose or your nose and mouth or your mouth. And I'm sure there's other permutations. And, before we talk about the other ways to fix someone's apnea or work on to improve it, what's wrong with CPAPs? Why do so many people have problems with them?
That's a great question, Rich. If you look at what the industry uses as a standard for CPAP tolerance or intolerance, it's about 50%. So that means 50% of the patients that are diagnosed with obstructive sleep apnea cannot tolerate that treatment. Part of the problem is the pressure that's involved to pneumatically blow open the airway, and a lot of people just can't handle that. And the other problem is a lot of people have nasal issues that they can't breathe through their nose, and a lot of times that's when they're put on that full face mask, and they sound like Darth Vader at night. And, it just blows the airway open. And, there are lots of issues for a lot of people in trying to be compliant with that. And that's an issue because this is a really, really, really deadly disease. And it affects a lot of Americans. And we need to have those people that have this disease that are intolerant of CPAP therapy be treated. So,
again, what is it about the CPAP that causes people to not like it? Do they feel like the air blowing in their mouth is choking them? Or do they just feel like they're being claustrophobic because of the mask? Or what happened?
Great question, Rich. A lot of it is claustrophobia, sinus infections. The gamut is huge on why people can't tolerate it. Imagine having all that air rushing through your nose and your mouth at night. They just can't handle that and tolerate it. And, CPAP is a great therapy for those people that can tolerate it. Unfortunately, what do we do with the 50% of the people that can't tolerate it? What do you do? Just let them go? So that's where dental sleep medicine comes into play.
Yeah, and just to cover what makes apnea such a bad disease, what can it do to people and over what time frame?
What a great question. So when I talk to my patients, a lot of people listening to this may not know what the word apnea means. And what I found in the last 13 years that I've been treating the CPAP intolerant patients is I rarely find that a patient will come to the practice that completely understands their disease. So the first thing that I like to help them with is to understand what the sleep study means. And let's kind of talk about what that's all about, Rich. In order for somebody to have a diagnosis of obstructive sleep apnea, they have to be screened. There has to be some type of diagnostic component to it. And that's either done through an attended overnight sleep study. And hi, my name is John. I have obstructive sleep apnea. So I have had 6 full-blown attended polysomnograms. That's what the word PSG stands for. And that means you go to either a hospital or a sleep center. You spend the night. They hook you up to 18 to 21 leads from head to toes, and they connect that all to a box. They hang the box on the side of the bed. They videotape you while you're sleeping, and they tell you to have a great night's sleep. Well, you can imagine that, Rich. It's not comfortable, and that is the industry standard. And then that information is interpreted by a RPSGT, that stands for Registered Polysomnographic Technician. And then that information is given to a sleep physician, and the diagnosis has to come from a board certified sleep physician. That's the only way you can have a diagnosis. Things have kind of changed in the industry, and more people are in the industry are turning to a home sleep testing device where you wear the device in the privacy of your own home and in your own bed. And that data is interpreted by a board certified sleep physician in your state, and then you get a diagnosis. So that's the way it goes. And we want to talk about apnea and hypopnea.
You've done 6 of these sleep studies?
Yes, but you have to understand, I'm obsessed with sleep. Once my line is when I speak, once the sleep bug bites you, you're in trouble. So I'd like to do a lot of research, and that's why I've been in the sleep lab so much. So let's try and help the listeners understand apnea, because we hear that word all the time, and what does it mean? So the easiest way for me to explain it to my patients is I actually have a cork in my office, and I hold the cork up to my airway, to my throat, and I say, imagine having a cork stuck in your airway for 10 seconds or longer. That's considered an apneic event, or apnea. So when I say the word apnea, I want you to think of cork in your airway for 10 seconds or longer. Then there's what's called hypopnea. And to help the patients understand what that word means, I have a straw, and I say, imagine breathing through a straw throughout the night. You would have some flow, but it would not be great flow. So if you breathe through a straw for 10 seconds or longer, that is considered a hypopneic event. And that's the way I help them understand the results of their diagnostic sleep study.
Yeah, my dad had apnea, and I remember when I was little, I didn't know what it was, but he would snore, and he would go, and I wouldn't hear anything for a few seconds, then he would gasp and start breathing again. And so to someone observing, that's what I experienced.
Yeah, well, that's kind of the same way I grew up, Rich. Excuse me. My dad was a champion snorer. And I remember him, he would quit breathing for what seemed like eternity. And as a kid, I would wake up and say, breathe, 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 so I can breathe. And, that time seemed like an eternity. And we see people that quit breathing for, as long as a minute and 30 seconds in a lot of cases.
That's crazy. Well,
he died the day after his 57th birthday. Right. And from cardiovascular issues, he was never sick a day in his life. He was a dentist. He was 6'5", 290 pounds. Interestingly enough, his brother and their father both died at the age of 57. And if you look back in the lineage, there has been no male that has lived past the age of 57 in 3 generations. So I made it. And here's if you put all the pieces of the puzzle together, they all had obstructive sleep apnea. But back at that time, no one was looking at airway health. So that's why I'm so passionate about this. Yeah, like I said, hello, my name's John, and I have obstructive sleep apnea. And oh, by the way, I'm CPAP intolerant.
Okay, well, it's good that you broke the cycle and you understand it. And like you said, now I understand why you're so passionate about it. Right.
Yeah, absolutely.
What are, again, just to reaffirm for people, what happens if you have apnea, and how long do people have it before it's diagnosed, and what can it do to you over what time period?
It's a great question, Rich. So according to a study done by ResMed is the world's largest leading distributor of CPAP devices. It takes an average of 5.2 years for someone to be diagnosed with obstructive sleep apnea. So, the big thing is, how do we identify the at-risk individuals, and, what is going to be the implementation of a strategy to slow or prevent the disease? It's all through the literature that we need early intervention. Care needs to be more accessible and cost-effective. I think you need to engage family members and primary care physicians, because this disease has severe cardiovascular consequences, diabetes, the cost for the untreated obstructive sleep apnea patient to the healthcare system and the workplace is about $4.3 billion a year, 77% correlation with diabetes, sexual dysfunction, stroke, GERD. And, it's basically, like we like to say, is 1 in 4 Americans are undiagnosed with this. And then, it's tied to depression, it's tied to Alzheimer's, it's tied to glaucoma, it's tied to cancer. So pretty much my line is, there is not one organ in the human body that doesn't fall victim to this disease. And, one of the big reasons is obstructive sleep apnea is a systemic inflammatory disease. And we have chronic inflammation of the body, and that leads to major problems. We have sleep fragmentation that leads to oxidative stress and glucose intolerance, and all that has an effect over the entire body.
I guess you could also picture that someone's choking you out, 10, 20, 30 times an hour all night long.
Yeah, I mean, we see, I show a video in my programs of a gentleman that is not breathing for 70 seconds out of 103 seconds of the video.
I don't think I can.
So we see, it's very disturbing. And the big problem is that they end up in this hypoxic state where they're not getting, oxygenation of all the cells of the body. And you'll see people that will desaturate down in the levels of 70%. So what does that mean? If anybody's ever been in the hospital and they're hooked up to all the leads and they're looking at, pulse oximetry, if your O2 desaturations go below 90%, the alarm is going off.
Right.
So just imagine somebody being at 70% for a minute and 30 seconds. It's very disturbing. It's bad for the entire body.
Not only that, I mean, what's the range of apneas? Like, some people have it, I've heard, 20, 30 times an hour. So, what if you're in bed for 8 hours and you have it 10 times an hour? It's 80.
Yeah, well, you
could have 100 apneas during the night. That's horrible.
That's nothing, Rich. So, it's called the apnea-hypopnea index, and 5 to 15 events per hour is mild obstructive sleep apnea. 15 to 30 events per hour is moderate obstructive sleep apnea, and greater than 30 events per hour is severe obstructive sleep apnea. I've seen patients that have had an AHI of 108. So you can do the math on that. 108 events per hour. That's crazy.
Yeah, that's horrible. At what level do people, I guess probably the only people that come for help are the people that are symptomatic, but is there a level at which someone could not be symptomatic? They wake up, maybe they're a little bit tired, but they feel fine all day, and then they go to sleep and they have apnea, they just don't know it?
Yeah, I mean,
because they don't have symptoms?
Yeah, if you look at the literature, the numbers are anywhere from 29% to 80% of the American population. It depends on what study you look at. So one of the ways, one of the ways we screen our patients in our office for potential airway issues, it's a form called Stop Bang. And it was just absolutely a great screening tool that was developed by the anesthesiology community to look for people that had obstructive sleep apnea and were not diagnosed yet. So what does it stand for? The S stands for, do you snore? The T stands for, are you tired? The O stands for obstruction. Has anyone seen you have events where you quit breathing at night? Those witnessed apneic events where you stop breathing. Right. And the P is pressure or hypertension. The BANG component is body mass index greater than 35. The A is age greater than 50. The N is neck size greater than 15¾ inches. And the G is gender, male gender. If you have a positive response to at least 3 of those, you're at high risk of having undiagnosed obstructive sleep apnea. So in my practice, we screen our patients for airway health. We don't use scary words like apnea and hypopnea for the undiagnosed patient. I like to talk about airway health. And then you can start to look at the medications that they're on. If they're on, antihypertensives, they're diabetic, they're taking medications for GERD, those are all clues for you that should help you in understanding that patient most likely has an airway issue. Then we can look in the mouth and we can look for a high vaulted palate. We can look for what's called a scalloped tongue, where there are indentations throughout the tongue. You can look at their gum situation. And it's funny that in a study that was done, 60% of the patients that had obstructive sleep apnea had periodontal disease. So those are some clues.
Quick question.
Sure, go ahead. Go.
Do people that breathe through their mouth have apnea more than breathe through their nose?
That's a great question, Rich. So if you look at some of the studies where they took normal individuals that did not have obstructive sleep apnea, and they put them through a sleep study, and they blocked their nose, and they became mouth breathers, their AHI went to 43. So that would mean they're severe, 43 events per hour. When they blocked their mouth and let them become nasal breathers, their AHI went down to 1. So there's a huge correlation with mouth breathing. We're not supposed to be mouth breathers. We were created to be nasal breathers. So if there's a problem with their nose, then that is another indication that there is probably an underlying airway issue.
Okay. And then with the, you said you saw evidence of periodontal disease in like 60% of people that had apnea?
Yeah, 60% of the people with obstructive sleep apnea have periodontal disease. And that's pretty high.
Yeah, I guess, I bet you that what happens is, this is my guess, but I bet you that breathing through your mouth more often, and it probably hanging open when you have the apnea, I bet you it alters the gut bacteria, or not the gut bacteria, the bacteria in your mouth, the microbiome of your mouth, and that the ones that are, aerobic tend to predominate instead of anaerobic, and that probably causes, this is my guess, it causes periodontal disease.
Yeah, I think that's a great answer, Rich. I think you have to look at the increase in the oxidative stress to the body due to that hypoxia. And then the other thing is this, that when you are a nasal breather, we emit nitric oxide. And nitric oxide is great for killing off viruses. When you're a mouth breather, you emit very little nitric oxide. So,
really?
Like I said, yeah, there's a correlation between everything in the body and sleep apnea. And being a mouth breather adds lots of issues. We know from a dental standpoint, drying out the mouth like that leads to increase in decay and as well as the periodontal condition.
Wait, so when you breathe out through your nose, what, nitric oxide gets entrained in your exhalation in your nose?
Yeah, no, it's through the inhalation. So nitric oxide is emitted, and that is critical for us in our health.
Really? That's weird. So when you breathe in through your nose, nitric oxide is emitted from your body and then gets entrained in the incoming airstream? Correct.
So, nitric oxide increases the efficiency of oxygen exchange and increases blood oxygen absorption 18% more than does mouth breathing. It's a huge, potent vasodilator. Huh. So it's really, really critical that we are nasal breathers. Nitric oxide release through nasal breathing is 6 times greater than that we find if in those patients that are oral breathers. And the greater concentration of nitric oxide is required to kill viruses in vitro. So, if you're not breathing through your nose, there are some major issues there for you.
That's amazing, because now I know why people say breathe in through your nose and out through your mouth. You're the first person
right. Well,
talk to that said why. Now it makes sense.
One of the great athletes, Lance Armstrong, was absolutely one of the greatest nasal breathers, and look what it did for him. And when I bring that up, people always say different things that I'm not going to comment on. But we all athletes know the importance of nasal breathing. I mean, look at the NFL and the number of athletes that use those breathe right strips, right? They're doing that for a reason, sleeping. Right? So it's just not sleep. I mean, they want to make sure their nose is open because, as I said before, you increase the efficiency of that oxygen exchange and increase blood oxygen absorption 18% more than if you breathe through your mouth. That's pretty cool stuff.
So is there a CPAP company that not only humidifies the air for mouth breathers, but entrains a small amount of nitric oxide to help breathing?
That's a great question. No, I've not seen that.
Well, that probably would be a good idea, right? If you could test that, then from, when you're awake, imagine if you had like a lozenge that you kept in your mouth that releases small amounts of nitric oxide, so that would get entrained in your mouth air. If you don't breathe through your nose.
That would be great. So first of all, I work with a lot of ENTs with patients that have nasal problems. We use cone beam technology in our practice, which is a 3D scan of the entire skull. So you can check out the patient's paranasal complex and their septums. And then there's a product called Mute, M-U-T-E, by Rhinomed, which goes inside the nose. It's a nasal dilator. And a lot of your athletes are using these now. It's called the Mute Turbine. And then we also use the Mutes to assist our patients in being nasal breathers versus oral breathers. It's a great product. Once you put them in your nose, it's like it completely opens up your nose, and you're like, wow, I can't believe how much air I get in.
How does it act? What does it do?
It's splinting it's dilating the nose open.
You know what?
It's a very cool product.
Another thought occurred to me. When you have sexual dysfunction, I would think one of the problems is you don't produce enough nitric oxide. I guess it's probably how Viagra works. So if this is, again, it's just speculation, but it's coming from what you're saying. If you have that dysfunction, I wonder if that hurts your ability to emit nitric oxide in your nose.
Yeah, there are a lot of other
between those two.
It's a great spot, Rich, but there are other issues that come into play, and we don't have time in this podcast to go down that road. But think of how many men have ED, and they've never had their airway evaluated. So you open up the airway, and your entire body gets healthy. I mean, what's the new big thing with men, right? I always say that in our programs, I pick out a gentleman, I'll say, hey, how's your tea? And I said, and I'll make a comment, I'm not talking about your English breakfast tea. And everybody's like, what are you talking about? Testosterone, right? So we know if we rectify the body and help it to breathe properly, the hormone levels come back up. So all good stuff happens when we treat the airway.
Okay, and I haven't even asked you, I'm sorry, about, how dentists can, certain ones, help people sleep better when they don't tolerate the CPAP. And from what I've heard, it's it's like a prosthetic that goes in the mouth that advances the lower jaw to keep the airway open, or?
Yeah, great question, Rich. So for the 50% of the population that are CPAP intolerant, my question has always been, what do we do for those individuals? Do you kick them to the curb and just let them go off into outer space and let them deal with all their medical issues, or do we try and look for alternative therapy? So that's where dentists that have a specific interest in dental sleep medicine can offer an oral appliance that does move the lower jaw or the mandible forward. And as you move the mandible or lower jaw forward, it pulls the tongue off the back of the throat and assists in keeping the airway open at night. So I've been wearing an appliance for the last 13 years. I had moderate obstructive sleep apnea. When I wear my appliance, I have no issues. I don't have sleep apnea then. And it's a great adjunct therapy for those patients that cannot tolerate CPAP.
So is it, what does it look like, the appliance? Does it like go over your teeth like a mouth guard, or what does it look like and feel like?
So, they're all custom fabricated. There are over 153 FDA cleared devices that we can choose from. I have my personal favorites. I've tried about 25 different appliances. They go over your upper jaw, they go over your lower jaw, and then there's some mechanism to either pull or push the lower jaw forward. And that's how all the appliances work, by advancing that lower jaw forward by either a push or pull mechanism. And they're highly effective.
With jaw pain, if it does this for hours and hours at a time?
Great question. If you fabricate the appliance properly, when you remove the appliance, you will have notice that your bite is off. So we have what I personally call a bite exerciser that helps to reposition the lower jaw in place. It's worn for 10 to 15 minutes while the patient's doing their normal morning routine. And very few patients have jaw joint issues if they follow our instructions properly and if the appliance is fabricated accurately and properly as well.
Okay. And then, I've seen like Snore RX. I even bought it years ago, and you throw it in a pot, it boils, and you stick it in your mouth, and it's mold to your mouth, but it didn't really work too well, and it seemed like, just like a giant mouthpiece. Are these fabricated in such a way not only that they're more effective because they're custom, but they're less intrusive in your mouth when you're sleeping?
So the devices that you're talking about are called the boil and bites that you just alluded to. I love it when patients come in with those, because typically, first of all, they're massive in your mouth, as you just alluded to. And I want an appliance that has low volume so I can maximize the oral cavity volume and give the patient room to have their tongue get up and out of the way. And typically, those boil and bite devices will cause a lot of jaw joint problems. So I'm not a big fan of those. Like I said, we see people that have tried those all the time and come in and we show them a custom-made device and see how comfortable it is.
Okay. And then what's the success rate with the jaw advancement devices? Are they tolerated by most people, or some people still can't take them?
Once again, another great question. The majority of our patients have a very high success rate and a high compliance. Once again, I think it depends on what device you select out of the over 153 FDA cleared devices for comfort and to minimize the volume of the appliance so that there's lots of room for that tongue to get up and out of the airway. And we have great results with our oral appliance therapy.
All right. And then is a sleep study and prescription required in order to get one of them? Or is it less of a pathway than CPAP?
No. In order for any dentist to appropriately treat someone with an oral appliance, you first of all have to have a diagnosis from a board-certified sleep physician. That diagnosis cannot come from a primary care physician. It's got to come from a board-certified sleep physician. Once you have the diagnosis, and typically the insurance companies like to see the patients try CPAP initially. Some insurance companies don't. And if the patients can't tolerate it, and we have a prescription to provide oral appliance therapy, we're absolutely good to go. And it is covered by the patient's medical insurance.
Okay, that's great.
So it's awesome. It's a win-win for everyone.
Have scientists observed experimentally if it's as efficacious as CPAP, or is it slightly worse or better?
So that is an awesome question. There was a big publication in 2015 that compared multiple parameters that kind of put CPAP and oral appliance therapy head to head, and it depends on what you're looking at. It depends on, there was a huge study done, it was called the SAVE trial, that looked at how long patients actually wore their CPAP. And the average CPAP user wore their appliance 3.3 hours a night. So the question then becomes, if you look deeply into sleep and look at what's called sleep architecture, the patient is only being covered for approximately a third of the night. Typically, oral appliance therapy users wear their appliance all night. So you're covering the disease for the entire night of sleep. So
yeah, I mean, that sounds dangerous to only use the CPAP part of the night, because that seems even, well, I don't know if it's worse or not, but I've heard stories of people having CPAPs and they don't use it one night and they die. So
absolutely,
you're kind of creating that effect every night by only using it for part of the night.
I have a colleague that speaks with me, and his brother died at age 37 with the CPAP under his bed.
Oh, man.
And so we hear stories like that all the time. So the moral of the story is this is a severe disease that does take people's lives. It's because of the associated comorbidities with obstructive sleep apnea that takes a life. And, as I always say to my fellow colleagues, dental peers, if you want to involve yourself in something that's absolutely going to have a huge impact on someone's life and has the potential to save a life, get involved with treating the CPAP intolerant patient with oral appliance therapy. It's absolutely life-changing.
Well, very good. So how, I know, unfortunately the entire world can't come to you. So if people are local, how do they get in touch, and, can they reach you? And then if they're not local, what are some resources for them?
Sure. So they can always Google, oral appliance therapy for sleep apnea, and that should bring up a provider's name in their area. The American Academy of Sleep Medicine has a website that you can go to their website, type in your location, and it will give you names of dentists that have a special interest in treating the CPAP intolerant patient with oral appliance therapy. And that's a great resource for people, because those, if you're a member of the American Academy of Dental Sleep Medicine, you've gone through a lot of training, and that's why you're part of that group.
Well, very good. Well, I appreciate you coming on the podcast. You have tons of knowledge about this stuff, so it's been a really great call.
Oh, thanks, Rich. I appreciate it. I'm honored to be on here, and hopefully this message will touch people's lives that have airway issues and can't tolerate CPAP and seek alternative therapy so that they can have a healthy, happy, long life.
You're listening to the Future Tech Podcast with Richard Jacobs. Future technologies such as artificial intelligence, stem cells, 3D printing, gene editing, Bitcoin, blockchain, the microbiome, quantum computing, virtual reality, and exploring space are much closer than you might think. In fact, many early versions of these technologies are in play right now, and the companies that are using these technologies are the focus of this podcast. My goal for you, the listener, is to learn from these podcasts. You may very well learn something that may change the course of your life for the better, steer you towards a new career, or give you insight into addressing a thorny medical problem. Remember, this podcast and its content is informational in nature only. No medical, tax, legal, financial, or psychological advice is being given. If you've enjoyed the podcast, please listen, subscribe, like, and tell your friends about it. Thank you.